Hello and welcome everyone. We are on week 8 and lecture number 37. And in today's lecture, we will understand the functional and objective testing for safe return to play. The objectives for today's lecture are to understand the role of functional and objective testing in return to play clearance, to learn validated clinical and performance based tests for knee ligament injuries, to recognize strength, hop tests, balance, and agility tests used in evidence based protocols, to appreciate the limitations of isolated tests and the need for a test battery, and to also apply objective criteria to reduce re injury risk and optimize readiness. So, without further ado, let's begin. A knee may look stable in the clinic but fail under game pressure. An athlete may not complain of any pain on walking, climbing stairs, performing a light jog, but the knee rehab was not carried out for performing these basic activities. The rehab was done to perform activities of higher intensity and demand. That's why we rely on testing and not just observation. Objective measures strip away any bias and guesswork in taking a decision. Hop tests, strength ratios, and movement quality all form an essential part of the return to play decision. Passing these tests is like a passport back to competition. This lecture will show you which ones matter most. Return to competition decisions cannot be based on time alone. Some athletes may recover earlier than others, depending on their age, their baseline conditioning, the structured rehab protocol that they followed, and their psychological readiness. Functional testing provides objective benchmarks to identify whether an athlete is truly ready. Studies show that athletes who do not meet these criteria face a significantly higher risk of re-injury. These tests also help reassure the clinician about safety of the athlete and the athlete's readiness to perform at the highest level. Functional tests replicate the movement of an athlete on the field. Functional testing is divided into several categories. First among them is strength test. Strength test is used to measure quadriceps and hamstring strength and compares it to the uninjured limb. We can also use it to measure the strength of the adductor muscles and the abductor muscles. Second is hop test. This test, which challenges power, symmetry, and dynamic stability, is used to compare the injured limb with the uninjured limb. The third test is the balance and proprioception test. This test is used to measure proprioception and postural control, something which is very essential for sporting movements on the field. And finally, we test agility and movement quality. These assessments help us check real-world sport demands. A complete assessment covers all these domains. Now, in the subsequent slide, let us discuss about each of these domains. Strength is critical for knee stability. Isokinetic dynamometer is a laboratory-based device that measures muscle torque across a joint at a constant angular velocity. It is considered the gold standard for objective muscle strength assessment, commonly used in ACL, PCL, and multi-ligament rehabilitation. A target of at least 90% symmetry compared to the uninvolved limb is widely accepted. In settings without isokinetic dynamometer, a portable device that measures isometric muscle force during resisted contractions is used. This device is called a handheld dynamometer. It is practical, inexpensive, portable, reliable, and can be carried on the field. The handheld dynamometer is quite accurate when performed with proper stabilization by the same observer. Useful for clinic-based strength assessments when isokinetic testing is not available. Other methods include 1RM testing and velocity-based testing devices. One repetition maximum is the maximum load an athlete can lift just once with proper technique in any given exercise. It provides a measure of maximal dynamic strength and helps guide strength training loads. This testing requires caution post injury, and overloading should be avoided. Velocity based training devices or VBT devices measure barbell or limb movement velocity during resistance training. They allow estimation of strength, power, and fatigue without maximal loading. These devices are increasingly used for safe progression and monitoring in rehabilitation and even in performance settings. Hop tests, as described before, are easy to administer and strongly predictive of lower limb function. The single, triple, and crossover hop tests measure power and control over distance, while the 6-meter timed hop test assesses speed and endurance. Importantly, athletes must achieve more than 90% symmetry and landing mechanics must be safe and efficient. A graphical representation of the test is as displayed on the slide. A 6-meter straight line is drawn or marked for reference. To your extreme left is the single leg hop test. In this test, the athlete performs one maximal hop forward on the involved leg, aiming to cover as much distance as possible while maintaining his body control. The distance is measured from the toe at the push-off to the heel at landing. It primarily evaluates unilateral leg power and landing stability. In the triple hop test, the athlete performs 3 consecutive hops forward on the same leg without pausing between landings. This test adds an element of endurance, neuromuscular control, and the ability to maintain balance over repeated efforts. Distance covered over all 3 hops is measured and compared with the uninjured leg. In the crossover hop for distance, The athlete performs 3 consecutive hops while crossing side to side over a central line. It introduces a multiplanar movement, testing lateral stability, dynamic balance, and coordination in addition to forward propulsion. The total distance is recorded and compared with the uninvolved or the uninjured side. In the 6-meter timed hop, the athlete hops on one leg continuously over a 6-meter distance as quickly as possible. Performance is recorded in seconds, emphasizing speed, reactive strength, and fatigue resistance. This test replicates the time pressure demands of sport specific movement. A limb, a limb symmetry index LSI more than 90% is commonly used as a criteria for safe progression towards return to play. In ideal scenario, athlete support staff can conduct these tests before the start of a sporting season. So in case if prospectively an athlete suffers a knee ligament injury, we would have a baseline test to compare the same limb before and after the injury. Slide number 9, balance and stability test. Dynamic balance is another pillar of safe return. The Y balance test and star excursion balance test are commonly used. Y balance test is used to assess dynamic balance, neuromuscular control, and limb symmetry during single leg stance. Scores of less than 90% symmetry indicate need for further training before return to play. Star excursion balance test is used to evaluate multi-directional dynamic balance, proprioception, and functional stability. Interlimb asymmetry of more than 4 cm is clinically significant. Single leg stance with perturbations is used to test static balance, reactive stability, and proprioceptive reflex control. Under challenge. Poor recovery, excessive sway, or loss of balance indicates deficient neuromuscular control. Improvement over sessions shows proprioceptive retraining progress, and deficits in balance have been linked. Poor recovery, excessive sway, or loss of balance indicates deficient neuromuscular control. Improvement over sessions shows proprioceptive retraining progress. Deficits in balance have been linked to higher re-injury rates, making all these tests very essential. Agility tests like the T-test or shuttle test replicate the demands of cutting and directional changes in sport. T-test is used to evaluate multidirectional agility, change of direction speed, and body control. Slower times or poor movement quality suggest deficits in agility or neuromuscular control. Shuttle run is used to assess acceleration, deceleration, and directional change efficiency. Poor times or loss of form during cutting indicate inadequate power or stability. Symmetry between sides should also be checked. The Illinois Agility Test is used to measure whole body agility, anaerobic capacity, and coordination in sports like movement. Longer times indicate deficits in agility, coordination, or conditioning. sport-specific lateral cutting drills to replicate game-like cutting demands and test dynamic stability under realistic sports conditions. Excessive valgus collapse, delayed reaction, or instability signals incomplete readiness. Passing criteria often include symmetry and safe biomechanics. I encourage everyone to search upon the net the names of these tests and look up on video demonstration on how these tests are performed. Performance is not just about numbers. The movement quality also matters. The landing error scoring system, or the LESS, identifies faulty biomechanics during jumping and landing tasks. These tasks that increase ACL injury risk. A score of more than 5 indicates high risk landing patterns. Lower scores reflect safer biomechanics and readiness for resuming sport activities. Drop jump video analysis is used to evaluate dynamic knee control and neuromuscular strategy during high demand landings. Excessive valgus collapse or asymmetry or stiff landings suggest poor readiness. Safe, symmetric, and controlled mechanics support return to play clearance. Video analysis adds precision in decision making. The functional movement screen is a broader test identifying mobility, stability, and movement asymmetries in athletes. A total score of less than 14 out of a possible 21 is linked to higher injury risk. Individual asymmetries are red flags for targeted intervention. Even when physically ready, many athletes hesitate due to fear of re-injury. The ACL RSI scale quantifies confidence and psychological readiness. The IKDC subjective knee form is a patient-reported outcome measure developed to assess symptoms, function, and sports activity in patients with knee injuries. It includes items on pain, stiffness, swelling, giving way, knee function, and ability to perform daily and other sports activities. Scores are standardized on a scale of 0 to 100, with higher scores indicating better knee function. The IKDC is widely validated for ACL, meniscus, and multiligament injuries and is sensitive to changes after surgery or rehabilitation. It is considered one of the most commonly used global knee function scales in both clinical practice and research. Knee injury and osteoarthritis outcome score, also called the KOOS. The KOOS is specifically designed to assess both short-term and long-term outcomes of knee injuries, including post-traumatic osteoarthritis. It has 5 subscales: pain, symptoms, activities of daily living, sport and recreation function, and knee-related quality of life. Each subscale is scored separately on a scale of 0 to 100. Just like the IKDC scale, higher scores indicate better knee function. The scale is frequently used in ACL, meniscus, cartilage, and osteoarthritis research, making it a highly versatile scale. Its ability to capture sport-specific and quality of life dimensions makes it particularly valuable for athletes undergoing knee rehabilitation. Combining psychological tools with physical testing ensures a more holistic assessment. No single test can fully capture an athlete's readiness to return to play. For example, an athlete may pass hop distance test but show unsafe landing patterns. Similarly, strength symmetry alone does not guarantee neuromuscular control. An athlete may score well on the psychological test but not perform well in the physical test. The individual needs to be ready both physically and psychologically to make a successful return to play. Evidence strongly supports use of a battery of tests across multiple domains rather than relying on one single test alone. The most widely accepted test battery includes 1. More than 90% strength symmetry by isokinetic dynamometer or handheld dynamometer. This is for strength testing. Second, the Hop battery of test with safe landing mechanics. Third is Y balance or similar dynamic stability test with more than 90% limb symmetry. And fourth, confirm psychological readiness by using the questionnaire-based systems. And finally, clearance for return to play is a team decision taken by the surgeon, the sports medicine physician, the strength and conditioning coach, the physiotherapist, and all must agree before the athlete makes a return to competition or to sports. With this, we come to the end of the lecture. The key takeaway from today's lecture are: functional testing is the cornerstone of return to play. Using multiple test domains like strength, hop, balance, agility, and psychological readiness provides better objective measurements of the readiness of an athlete both physically and psychologically. The criteria-based clearance reduces the risk of re-injury, and like I've mentioned before, there's no one-size-fits-all. The protocol has to be designed according to the athlete's need and sports demand. These are few of the references that I have mentioned in my lecture today. I'll be seeing you for the next lecture. Till then, thank you and goodbye.